My name is Matthew Sterling. Today I'm going to talk about BPH, or benign prostatic hyperplasia. Just as a reminder, you will get an email with a recording of this, ideally within a week. If you can't catch everything, we should be able to get a recording for you. A little bit about myself. I grew up in South Jersey, went to college at Penn State, so I am a huge Penn State fan for those patients out there that have seen me. I went to medical school back in New Jersey at Rutgers, did my residency in urology at Penn, and then did a fellowship in reconstructive urology. And really my main focus is on benign urology. So BPH, voiding dysfunction, minimally invasive surgery for BPH, stricture disease, incontinence. That's really, where my specialty is and where my interests are. So this talk is really going to be about BPH. We'll talk a little bit about the pathophysiology. We'll talk about treatment options, and then we'll review some of the surgical options that patients can have. So BPH refers to benign or non-cancerous enlargement of the prostate. And it is super, super common. And as the population ages, it's becoming more and more prevalent. So 50% of patients over 50 have some sort of BPH, and more than 90% of patients over 80. So it's really something I see very commonly in my practice. And there's really multiple factors associated with it, but the most common reason is age, potentially hormonal factors as well. And there's some genetics also. So I like to talk a little bit about some of the pathophysiology. And so you can see here on the one side, as the bladder fills, what can happen is you feel pressure as if you have to urinate. And then I like to tell patients the prostate is essentially like a donut surrounding the urethra. And so when you're younger, that opening is much smaller. As you get older, as you can see on the side, the opening gets smaller. And so it can be much, much, much more difficult for patients to urinate through that smaller opening. And so what can happen is patients can start to develop significant urinary symptoms, such as urinary urgency, hesitancy or trouble starting your stream, weak stream, urinary frequency, interrupted stream. I have a lot of patients that will have to push or strain to urinate, which can be really, really painful for patients. Sometimes patients can't empty their bladder. And so long term, this can lead to urinary tract infections, which is very common that we see in our practice. It can lead to bladder stones, kidney failure. So this is usually a long-term problem that patients can have, urinary leakage or incontinence, where urine comes out when you don't want it to, and potentially long-term can lead to bladder damage or the requirement for a urinary catheter or urinary retention. It does not increase your risk of cancer. So a lot of times patients will come in with urinary symptoms and they think they have a prostate cancer. The vast majority of patients that have urinary symptoms do not have a cancer. It's just benign or a non-cancerous enlargement of the prostate. So how is this diagnosed? So the first thing, and probably many of you have come to our office and seen, some of the things that we'll do to help diagnose BPH, but we'll often do a digital rectal exam or a prostate exam. We'll often do a bladder scan to make sure that patients are emptying their bladder, which is really important and especially good in following patients with BPH. We'll often give you a symptom score or a little survey to fill out, and that'll give really good objective data for how patients feel that they're urinating. We'll oftentimes check a PSA test to see if there's any potential prostate cancer. And then we'll check a urine test. Is there any blood in the urine? Is there any concern for infection? Other tests that we might do, so we might have patients urinate into a flow to see exactly how fast. Some patients will come and tell me that they're voiding normally and then their flow is really weak on one of these tests that we do in the office. There's a test called Eurocuff, which we'll start doing soon, which is a non-invasive test to really determine the bladder function or the bladder pressures. There's urodynamic testing. So this is really the most detailed assessment of voiding parameters. Some of you might have had this. We stick a small catheter inside the bladder, a small catheter where you poop, and we basically fill up the bladder over the course of 15 to 30 minutes, and we take measurements as the bladder's filling, and then we take measurements as patients are urinating, and that gives us an idea of how hard their bladder is working to urinate, if there's any overactive bladder. And it also allows us to tell if they're emptying their bladder. We'll often perform a cystoscope, especially if we're considering surgery or if we really are unclear exactly of what's going on. We stick a small scope into the tip of the penis to look at the urethra. We're looking for any scar tissue in the urethra, which is something I also manage. We'll look at the shape of the prostate. We'll look at the bladder, look for any bladder stones or potentially any bladder abnormalities such as tumors or irregularities that could be contributing to the way that patients are urinating. I'll often do a transrectal ultrasound if I'm going to plan for surgery. This tells me the exact size and shape of the prostate. So some surgeries are really good for certain sizes and shapes, and some surgeries are not quite as good. And so this will help me determine how I can best treat patients. So once we kind of figure out exactly what's going on, we'll then talk about ways that we can improve things. So there's lifestyle changes, there's medications that you can try, and then potentially surgeries. And so most things in urology, we like to start with non-surgical options first. So lifestyle changes or potentially medications, and then consider procedures either in patients that don't want to take medications long-term or in patients that fail oral therapy. So what are some lifestyle changes that I talk about? So I talk to everyone about this most of the time. Decreasing liquids, especially a few hours before bedtime if they're waking up a lot at night to urinate. Double voiding, so going back to the bathroom after 15 to 20 minutes to completely empty the bladder. Avoiding things that irritate the bladder, so caffeinated drinks, sodas, coffees, teas, alcohol, citrusy foods, spicy foods, or sugary foods. All of these things can irritate the bladder and contribute to patients' urinary symptoms. We'll talk about avoiding certain medications. So diuretics. So obviously these are not medications that I prescribe. So I'll tell people to go back to their primary care physician and see if there's any changes to medications that we can make. Avoiding constipation is really, really important. Beware of over-the-counter medications. So there's a lot of medications where people say we have the perfect fix for your prostate or your bladder, and oftentimes those medications really have no data or evidence that they will help you. It's also important to avoid, certain medications. Antihistamines can certainly contribute to some abnormal bladder function or decongestants as well. Some medications that we'll consider. So either the first time patients see me or if they've failed behavioral changes, we'll try some pills that can help. So when patients urinate, what happens is the prostate opens. So imagine again that donut, that donut opens as patients urinate. And so if the prostate's bigger, that opening is much smaller. And so alpha blockers such as Flomax, which is usually the first thing we'll start, or Uroxetrol or Rapaflow, what they do is they actually cause the prostate to open up more as patients urinate. And so it can make it much easier for patients to urinate and improve the efficiency with which patients urinate. 5-alpha reductase inhibitors are medications that actually shrink the prostate. They take about 6 to 12 months to work. I will say personally, I don't love those medications. They can have more sexual side effects, ED, ejaculation issues, libido issues. There's some newer data showing potentially higher depression rates long-term. I will typically recommend those in older patients that really want to do everything they can to avoid surgery, patients with recurrent bleeding related to the prostate, or potentially patients with a very, very large prostate. So in patients that fail medical therapy, meaning they have persistent symptoms beyond medications, or patients that really don't want to be on medications, we talk about procedural options, okay? Oftentimes before moving on to any procedures, I'll perform a cystoscopy, a prostate ultrasound, and urodynamics. You really want to understand exactly the size and shape of the prostate, exactly what's going on before operating on patients. It's really important. And that'll tell me if patients are going to have a better outcome or have a higher chance of having a better outcome. Most of these procedures are covered by insurance. Every insurance is different and does have very specific regulations for what procedures we can offer them. So I'm going to go through a few different options. I'm going to start with a few minimally invasive options and then talk to you about other potential options. In general, the minimally invasive options have less risk associated with them, but they don't typically have as good of results, and they don't typically last quite as long as some of the other options that I'll talk about. So UroLift is something that most patients know about. It's a minimally invasive procedure where essentially what I do is I put a scope inside and I put a needle into the prostate and then a suture. And essentially those sutures squeeze the prostate and they move the prostate or lift the prostate out of the way. What this does is it creates an opening. So again, when patients are urinating, it makes a bigger opening to allow patients to urinate more efficiently. I typically do this at our surgery center. It's an outpatient procedure. I usually give sedation for this, although you can do this under local anesthesia. And 70% of patients will not have a catheter after this procedure, which is one of the biggest benefits of UroLift. The other benefit is that it has the quickest recovery out of all the procedures that we perform. So every prostate procedure is going to cause some irritative symptoms: urinary frequency, urgency, burning, potentially blood in the urine. Most patients, that's only lasts 7 to 10 days with UroLift, which is a really short amount of time. It also has no risk of erectile dysfunction, no risk really of leakage, or very low risk of leakage, very low risk of scar formation. And no tissues removed, which is also a big benefit. And so, this is really a good minimally invasive option, low risk associated with it. However, you need to understand the success rate, meaning your improvement in flow is not going to be quite as good as some of the others I offer, and the risk of recurrence. So about 10 to 15% of patients are going to need more surgery within 5 years of this procedure. Resume is another minimally invasive procedure. It works essentially equally as well as UroLift. And so this is done in the office. So patients are awake. It's done with local anesthesia. I stick a needle into the prostate similar to UroLift, except instead of putting a suture, we put really hot water. And so what happens is that water vaporizes the prostate, and then over time, that tissue shrivels and dies, and it gets reabsorbed by the body, or you urinate small pieces of that out. The treatment takes less than 5 minutes. Usually each treatment's about 9 to 10 seconds. Usually give anywhere between 4 and 6 treatments. I leave a catheter for 3 days usually. In patients with a history of urinary retention, I might leave a catheter for a little bit longer. I tell patients you will get worse before you get better. So patients often will get frequency, urgency, burning, potentially bleeding for the first few weeks. I have some patients that last longer, but most patients it's 2 to 4 weeks. Similar to UroLift, there's a very low risk of erection issues, very low risk of ejaculatory or sexual function issues, very low risk of leakage issues, less than 1% risk of scar tissue as well. And so this is also, again, a really good minimally invasive surgery, low risk associated with it, done in the office, quick, fairly straightforward. Again, success rates similar to UroLift, not quite as good as some of the options I'm going to talk about here. In terms of retreatment rate, about 5 to 10%, so a little bit better than UroLift. So again, these are things I talk to about patients. I have a sheet, I go through all this, and then essentially allow them to make the decision for what they want. So 2 other procedures that I'm going to talk about is TURP and Aquablation. TURP is really a tried and true procedure. It's been around for over 100 years, essentially. This is done with patients asleep, definitely. We stick a scope into the tip of the penis, into the urethra, and essentially core out the prostate. So again, think of that donut. We kind of core it out in Roto-Rooter and create a nice big opening for patients to urinate through. Typically, I keep patients in the hospital overnight, although I don't have to, but that's kind of my practice. I usually leave a catheter for 2 to 3 days afterwards. The recovery is a little bit more challenging than some of the more minimally invasive procedures. So patients are going to get some frequency, urgency, burning, on and off bleeding. Majority of patients, I tell them every 2 weeks that's going to improve. Most patients, that has resolved by 6 weeks after surgery. Some patients take a little bit longer. The risk of ejaculatory dysfunction is certainly higher than the others. About 50 to 70% of patients will not ejaculate when they orgasm. There is a low risk of erection issues. There's a low risk of scar formation or stricture formation, about 5%. There's a low risk of urinary leakage, about 1%. But the success rate versus UroLift and Resume is much better, about 2 to 4 times as good flow rate, and the risk of needing more surgery is only about 2 to 5% long term. And so it's a really good long-term procedure But again, versus UroLift and Resume, maybe has a little bit more risk associated with it. Aquablation, I like patients to think of as essentially like a new age TURP. It's essentially a robotically assisted TURP. And so how I do this is there's a prostate ultrasound. So this is a real-time image guided procedure. I stick a scope right over the prostate. That scope has a robotic arm with powerful water. And so what we do is we use software to map out the prostate using the ultrasound. We map out all the different aspects of the prostate that we want the robot to resect. And then using heat-free water jet, we resect the prostate, and it takes about 5 minutes to do that part. I'll then put a scope in and cauterize and remove any additional tissue that looks obstructing. It's quicker than a TURP, so it takes me about half the time as a TURP to do, if not more. You can do this on very large prostates. So TURPs usually up to about 80 grams, whereas Aquablation, we can do up to 150 grams, if not more. It's image guided, which again is a little bit more accurate in what tissue you're resecting. I keep people overnight. I leave a catheter for 2 to 3 days, similar to TURPs. I tell patients the recovery is going to be similar to a TURP. You're going to have frequency, urgency, burning, on and off bleeding. The majority of patients, by 2 to 4 weeks, that's improving, and by 6 to 8 weeks, that's resolving. Rarely is it beyond that. It has a low risk of erection issues. It has a much better preservation of ejaculatory function than a TURP. So as I said, a TURP, about 50 to 70% of patients will not ejaculate, whereas with Aquablation, that's only about 10%. The leakage risk is lower, less than 1% risk of leakage. And there's some studies showing for larger prostates, so prostates more than 50 or 60 grams, that an Aquablation has better long-term success. Again, TURP, Aquablation, better long-term success, slightly higher risk than Resume and UroLift and some of the minimally invasive procedures. And that's up to the patient to decide what they're willing to do. In patients that have some of the more complications, so recurrent bladder stones, kidney failure, retention, these bigger procedures, TURP, Aquablation, are really going to provide the most benefit. But in my practice, I really leave it up to the patient. I give them the options, and then we sit down and talk. For patients with really, really large prostates, so more than usually 150 grams or plus, which is probably about less than 10% of patients that we see, we do a robotic simple prostatectomy. So if you think of the prostate like an orange, we essentially remove everything except for the peel. That's done robotically with 5 small incisions, actually through the bladder. So this is a surgery with incisions. It's an excellent surgery, again, for the most large prostates. Patients stay in the hospital overnight. It's performed with general anesthesia. Catheter time is a little bit longer, so 7 to 10 days typically, instead of 2 to 3 days with other procedures. And there's incisions, so there's a little bit of a recovery associated with that. Similar to some of the other procedures, there's a low risk of erection issues, ejaculation issues. The risk of leakage is a little bit higher, about 5% versus 1% with the others. Patients will have blood, frequency, urgency, burning, similar to other prostate procedures. But again, for really, really large prostates, this ultimately ends up being the majority of patients' options. So just to review, patients with BPH will often start with behavioral changes. We'll start with medical therapy. In patients that fail medical therapy, or they want something where they can come off of medications, we talk about procedural options. And the procedures really depend on the function of their bladder. So the urodynamics testing, the scope, the ultrasound, that tells me the shape and the size of the prostate. And then we go through options. And so every option is really different, and we tailor that to each patient. And then we go through the benefits of each surgery and the risks. And then ultimately, as I said, I kind of have a conversation with the patient, and I let them decide based on what risks and benefits, they would prefer. Everyone's different. And so this is really a quality of life problem. And so we kind of work together to come up with a solution that's acceptable for each patient. So now I can go through any questions that patients have. So I'm kind of just going to go through when they come through, and then we can potentially we'll bring up more questions. I'll stay here for a little bit. Okay, so if one has BPH and a PSA of 16, why is a biopsy needed? So anytime someone has an elevated PSA, so that's age dependent, but most patients will, say a PSA of more than 4, you really need to rule out prostate cancer before we do any sort of benign treatments for BPH. And so if someone has an elevated PSA, and a PSA of 16, I would say is very elevated, in my practice, we would get an MRI of your prostate first to rule out any prostate lesions, and then, typically recommend a biopsy before any sort of benign prostate procedure. So you need to make sure there's no cancer before treating the benign prostate problem. Does BPH affect sexual function? They often go together. It doesn't necessarily mean that BPH causes sexual dysfunction, but BPH obviously happens more often as patients get older, as well as erectile dysfunction and sexual function. And so they go hand in hand. A lot of times treating the BPH can improve patients' sexual function, but that's not the ultimate. The ultimate goal is to improve patients' urinary symptoms by improving their BPH. Someone asked about green light. So green light is really a technique. Green light laser is essentially a TURP using a laser. I do those as well in very specific situations. Obviously, if patients request, I'll do it. It has a lower bleeding rate. So patients that can't come off of blood thinners, so Plavix or Eliquis or Coumadin, I will offer them a green light because it has lower risk of that. However, it does have a tougher recovery. So patients will get more frequency, more urgency, more burning than a traditional TURP or an Aquablation procedure. And so in my practice, I've moved a little bit away from green light because patients are much more miserable after that surgery than others that I've seen, but it is certainly an option. And in patients, that have bleeding potential, I would say green light is usually going to be my number one. When you refer to erectile dysfunction risk, is there typical permanent, or it can be improved with the common ED medications? So I would say erectile dysfunction with these surgeries is pretty uncommon. And if happens, usually is treated with oral therapy, so Viagra or Cialis. Very rarely have I had a patient with any of these procedures that have had erectile dysfunction that we could not fix with oral therapy. If they do have it beyond oral therapy, it likely was there before and not a cause of surgery. Someone's asking to talk about HoLEP and Optilume. So HoLEP is not a procedure that I do. It's really only done by a very small percentage of urologists. It's a very challenging procedure. There's a few guys in the area that do HoLEP. Studies have not shown HoLEP to be any better than TURP or Aquablation or robotic simple prostatectomy, and is a very technically challenging procedure to do. It is a great procedure for BPH. So if you have someone that does a really good HoLEP, and there's a few guys in the area that do, HoLEP is an excellent procedure. But again, no data has shown that it's any better than the ones that I've talked about tonight. Optilume is a newer procedure. I will likely be offering that in the next year or two. It recently was FDA approved. Optilume is a procedure where essentially we take a balloon and we dilate the prostate using a chemotherapy agent, paclitaxel, coated on top of the balloon. The preliminary data, so there's some studies that have come out that are now 2 years old that look excellent. It's a minimally invasive procedure. I'm excited about it. I just typically in my practice like to wait about 3 or 4 years for more data to accrue over time. As data comes out, I like to look at retreatment rates after a few years. I like to look at potential any weird complications that people are seeing. So definitely something I'm going to be offering probably in the next few years. It's a really exciting new technology that's coming out, at least for patients that want a more minimally invasive option. With UroLift, are the foreign bodies left in with the clips? Yeah, so it's a suture with clips on the end. These are left in place. They're not removed. So I do have some patients that is of a concern. And so choose a different option than UroLift. Most patients, that doesn't bother them. It's not something that would cause any pain. In rare situations, if the UroLift clips are placed too close to the bladder, you can get stones that form on the UroLift clips. That is not a common complication, but that's something that you can certainly have in that area. Is it good for the prostate to drink a lot of water? Obviously, it's good to be hydrated, 6 to 8 glasses of water per day, in general is the recommendation. Obviously, every single person is different. So, some people have to water restrict or drink, can't drink too much. It really, I would just say in general for your health is good to be hydrated. It's not going to necessarily do anything more for your prostate. Are there any health issues that argue against surgery? Are some men poor candidates for any of these procedures? So some men definitely can be poor candidates. So based on prostate size and prostate shape. So, everyone is not a candidate for UroLift. Everyone is not a candidate for Resume. Everyone's not a candidate for Aquablation or TURP. And so every person is different. And so that's why when you're deciding what surgery, you should have a scope, you should have an ultrasound. It's really important to have a complete evaluation before getting offered anything for surgery. And then, patient's overall health status is really important. Patient that has, new stents and can't come off of aspirin and Plavix for 6 months, that's a patient you probably are going to want to wait 6 months until they can come off their blood thinner. So some patients really are not good surgical candidates for health purposes, or not good surgical candidates, because their bladder doesn't work or their prostate is a certain size. And so it's very individual. So that's something that we review together and come up with a game plan together. What are some triggers for these procedures? So the biggest trigger really is patients' annoyance with the way that they urinate. So most patients, I'll start on medications first. And if they're annoyed beyond medical therapy, then we'll talk about potential surgeries. The other triggers can be acute urinary retention that doesn't improve. So patients need a catheter. Medications oftentimes will not just fix that. Kidney failure or recurrent bleeding. These are triggers that medications are not necessarily going to help. And so sometimes we'll try medications, but a lot of times we might go right to surgeries. So someone asked about prostatic arterial embolization. I would say, so some academic centers are starting to do that. I do think some Mid-Atlantic urology might start to do that. PAE is a good option. Basically, what we do is an interventional radiologist uses a small pellet to embolize the blood vessels to the prostate. I would say the data I've seen is mixed. So there's some data showing it can be similar to a TURP. There's other data I've seen that it's not nearly as good as a TURP, with potentially higher risks. You get definitely more pain afterwards. There's a higher risk of readmission. About 40% of patients can get readmitted due to pain. And so I am personally I haven't seen enough good data to say that prostatic arterial embolization is the way to go. Now, I would say in specific situations, so patients with urethral strictures where it's difficult to place, the scopes we need for these surgeries, older patients where general anesthesia might be unsafe, patients with recurrent bleeding, PAE might be a great option for those patients. And so that's kind of where I'll use it in my practice. Any information regarding cryogenics? No, I don't know anything about cryogenics for BPH. I know cryotherapy can be used for recurrent prostate cancer. It has a lot of side effects. I am not, as a reconstructive urologist, I can tell you I am not a big fan of any cryotherapy. Must catheters be changed while recovering? The catheter remains in place. So usually we keep a catheter for 2 to 3 days for these procedures. And so, it's the same catheter. It's hooked up to a bag. You just drain the bag every time the bag fills up. Most patients tolerate it fine for the few days. Some patients do get significant discomfort with the catheter. For patients who had UroLift 5 years ago and is having recurrent symptoms, is a second UroLift considered? I will tell you, in my practice, I typically would go on to either a TURP or Aquablation. In someone that's failed UroLift, you potentially could do a second UroLift. Again, that's very patient specific. I would only offer that in older patients that maybe would not be good candidates for a bigger procedure or couldn't tolerate general anesthesia. Typically, if one of the minimally invasive surgeries, UroLift or Resume, fails, then I usually will recommend either a TURP or Aquablation. I don't love doing a surgery that, if patients have failed a minimally invasive surgery, doing it again. But every patient's different. So it's, some patients are not willing to have a surgery that has higher risks. And so, maybe I'll do it a second time if patients want to do that, understanding there's a higher chance of recurrence down the line. Aquablation versus Urolift, which is better for a 75-year-old for recovery and sexual function. That's very, every 75-year-old that comes into my office is completely different. So those are totally different surgeries. Aquablation is going to have a much better chance of improving flow, getting people urinating back to their normal, and has a lower retreatment rate, about 2% with time. Urolift, less risk. So yeah, there's less risk of erectile dysfunction. There's less risk of ejaculation dysfunction. So less than 1% versus 10% with Aquablation. Erectile dysfunction is about 5% or less than 5% with Aquablation. It's less than 1% with Urolift. So slightly better recovery, slightly better sexual function for Urolift. But again, these are totally different surgeries. It's hard to compare the two. Is there a maximum age beyond which surgery is contraindicated? I would say no. I try not to make decisions purely based on age. I look at patients' overall health. And so a really healthy 95-year-old is going to be a better surgical candidate than a really unhealthy 70-year-old. And so age is not really something, that I necessarily look at. Now, I will say for Aquablation, a lot of insurances and Medicare will not allow that procedure, will not cover the procedure in those over 80. And so unless they change those stipulations, for right now, Aquablation can't be offered in those over 80 for most insurances and for Medicare. Can you talk about iTind? So iTind is a procedure where you put a temporary, basically, stent into the prostate for a week, and then you take the stent out and kind of creates an opening. I probably need to read a little bit more of the literature regarding iTind. The studies that I've seen are just okay. Not quite as good as Resume or Urolift in terms of flow improvement or recurrence rate. And you need a second surgery, so you need to go back in and remove the device. At the moment, I'm not offering it because I haven't really seen, again, great data. None of the people in the academic centers I know are offering it. I'm at the moment, I'm not into iTind. I'll certainly look more about it to maybe understand it a little bit better. But at the moment, it's not something I'm going to be offering to my patients. Can strictures be removed if found while going in or doing one of the procedures? Yeah, strictures are a different beast. So it really depends. Some of these procedures can result in strictures, especially if patients have a smaller urethra than others. The scopes are just a little bit bigger that we have to use for some of these surgeries. We can certainly dilate strictures to do one of these procedures, definitely. Retreatment rate for Aquablation is around 2%. The data is about 5 years old, so we'll see. As the data accuse a little more. Most data they won't look beyond 5 years, so we'll see if they continue to look. It's about 2%. How do I decide how a patient has failed medical therapy? So if you have persistent symptoms beyond medical therapy and you're bothered, to me, you have failed medical therapy. Now, if you're not bothered enough to want surgery, then that's up to you. But in patients that are persistently symptomatic and are on medications, in my view, that's a patient that's ready for potentially more than just medications. And so we'll talk to patients about surgery in those situations. Patient had a TURP 15 years ago and continues to have symptoms. It really depends. So I would do a scope. I would do an ultrasound. I would do urodynamics. I would make sure there's no scar tissue where your TURP was. A lot of patients will just have regrowth of the prostate. In those situations, you could do another TURP. You can do an Aquablation. You can do Urolift, Resume. You really have all options on the table. So it's very independent for every individual. Physical activity that can help an enlarged prostate. I tell patients maintaining a healthy lifestyle. There's no specific physical activity that's going to make your prostate better. And so, unfortunately, there's no activity that I can tell you that's going to really impact the prostate. Do these surgical procedures lower PSA? So these procedures typically lower PSA because sometimes patients' PSA can be elevated because the bladder is working hard and pushing kind of through the prostate. And so that can cause your PSA to be elevated. And so if we relieve that obstruction, a lot of times your PSA is going to come down. Now with the TURP and Aquablation, where we're actually getting rid of tissue, you're going to see a decrease in your PSA because we're physically getting rid of prostate tissue. And so you're oftentimes going to see a decrease in your PSA. Now in someone that has cancer, you might see a decrease. And then if you follow it over time, it might increase rapidly again. And so obviously, we would follow patients similar, to those that have not had surgery and continue to monitor their PSA and make sure that it's not rising. I would say Aquablation and a TURP is equally invasive. So the question was, is Aquablation less invasive than a TURP? The answer is no. So they're equally invasive procedures in my view. Are there other situations where robotic is recommended other than a very large prostate? The only other situation I recommend it is in patients with stricture disease that I think is going to worsen with a TURP or an Aquablation. And so in those situations, I will oftentimes recommend a robotic simple prostatectomy or consider prostatic arterial embolization. But most of the time, it's going to be for just a very large prostate. The only other situation is if a patient has a very large volume of bladder stones and we're going to remove the bladder stones and the prostate at the same time, or if they have a large bladder diverticulum, I might offer it at the same time. Give me a second. Which procedures offer the best longevity? Is there a procedure that lasts for 20 or 30 years? I would say a TURP or Aquablation at the moment is going to give you the best longevity. They typically don't have data for that long of time. And so it's hard to say whether something's going to last for 20 or 30 years. I don't think that's really realistic to ask. But, a TURP and Aquablation, I would tell you, is going to give you the best chance of longevity. That's the last question I see. I'm happy to sit further if others have more questions. There's a lot of good questions out there, so I really appreciate everyone for the interactive session. Patient asks, if I can live with the symptoms, what are the risks to the bladder? So if your bladder is obstructed, the potential risks is that your bladder is going to work really hard to urinate, and over time is going to get tired, not work as hard, and go into retention. And so the risks of, patients living with this, if their bladder is really working hard, is they don't empty their bladder, they get urinary tract infections, they go into urinary retention, and require a catheter. So that's really the biggest risk. So I see a lot of patients that are symptomatic that really don't want me to do anything more. Those patients we follow, we check we make sure they're emptying their bladder. Sometimes I'll check ultrasounds, once a year or every few years to make sure that they're emptying their bladder on a formal ultrasound, make sure their kidneys look okay. As long as those are all okay, there's no real long-term damage. We just have to follow patients closely. TURPs have about a 2 to 5% chance of needing something done within 5 years. So how long does a TURP last? A good TURP can last a long time. Patients can certainly have regrowth of tissue. There's not a specific time frame, but it does have a low risk of retreatment. Is Cialis effective for BPH? It is effective. So Cialis taken 5 milligrams a day is a good option, especially for patients with concurrent erectile dysfunction. And so it's often something I'll employ in patients with BPH and erectile dysfunction. So oftentimes we'll improve quality of life for urination, we'll improve flow. And so certainly Cialis 5 milligrams daily is a good option for patients with BPH concurrently with erectile dysfunction. Recovery time for Aquablation and for TURP. I tell patients, you're going to hate me probably for 2 to 6 weeks for both procedures. I would say Aquablation might have a slightly easier recovery than a TURP from what I've seen. Patients will have frequency, urgency, burning, on and off bleeding. I tell patients the first 1 to 2 weeks are the worst. Typically 2 to 4 weeks starts to get better, 4 to 6 weeks. And then usually by 6 weeks, most patients, both Aquablation and TURP, are feeling more normal. I have some patients for both that takes longer, but that is not common. I would say at the moment I'm seeing a little bit better Aquablation versus TURP, but I would say it's fairly similar between the two. there anything to help BPH naturally? Exercise, avoiding vitamins, lifting weights. So lifting weights or workouts do not create BPH. It's just, unfortunately, patient's genetics that can contribute. You know, if you go there's all these infomercials about things that will, you know, shrink your prostate or these. There's really not great data for that, at least at the moment. Obviously, you never know how things can change. I tell patients living a healthy lifestyle, exercise, you know, eating right. These are all good things for your overall health and your prostate. Unfortunately, you know, it's just not something that you can exercise, lose weight, and all of a sudden your prostate problems are going to go away. That's just not how prostate issues work. And so again, just living a normal, healthy lifestyle is the best thing that you can do. What if your bladder will not tolerate a catheter? You know, no one likes having a catheter. It's, you know, it can cause irritation, frequency, urgency. And so, yeah, it's hard to answer that question. Most patients are able to tolerate a catheter if we need it. Do I perform most procedures within my pod? I would say, you know, half of us perform BPH procedures. In terms of UroLift for Zoom, I'd say I do majority of those in our practice. And aquablations, I'm the only provider in my practice that offers aquablation. In terms of TURPs, you know, most of my partners and I do TURPs, so I'd say we're probably pretty even in terms of TURPs. And then robotic simple prostatectomies, two of my partners do those who specialize in robotic abdominal surgery. And so I do not do those. I refer those to my two partners that specialize in robotic surgery. So I'll stay on for a few more minutes if anyone has questions. Again, I appreciate it's been very interactive. Thank you. All right. Looks like that's it. I don't have any more questions. Thank you guys very much. You know, if you need us, we are at Bryn Mawr and Conestoga Road. Our number is 610-525-6580. There's some information about our practice there. We really, really appreciate you guys coming out tonight. Hopefully everyone found this informative. Really appreciate the questions and the back and forth. Thank you again. Take care.